to my YouTube channel. And this lecture today is regarding the rationale and controversies of neck dissection. And that's one of the important topics for all ENT trainees and ENT consultants, as well as specifically working in the head and neck areas. Let's start by simple terms and some definitions and agreed on, and then we talked about some concepts, and then we can review the rationale of neck dissection everywhere in the head and neck. So first of all, what's the definition of neck dissection? Neck dissection is basically I have to remove the lymph nodes and the lymph-bearing structures, because like the lymph nodes, it doesn't have a lymphatics, and these lymphatics run into channels in the fat between the lymph nodes or the fatty tissue of the lymph nodes. So the fibrofatty tissue, the lymph nodes around three important structures in the head and neck area, especially when we're talking about the lateral neck, around the spinal accessory nerve and 2A and 2B, like we will talk later on about the levels of the neck, and the internal jugular vein, and underneath the SCM, and everything between the investing layer of the deep cervical fascia, which is investing the SCM, going up to the mandible, encasing the parotid and the submandibular gland, and the deep layer of deep cervical fascia, which is just above the level of the rootlets. Anything containing lymph nodes or fibrofatty tissue, when you're doing a neck dissection, you have to remove it. And that's what's called a selective neck dissection or lymph node comprehensive neck dissection. And that depends on the levels you are doing. If you're doing different levels of the neck, you can name it as a selective neck dissection based on the location of the neck dissection. If you remove all the package, like the fibrofatty tissue, the lymph nodes and the lymphatics, and the three important structures through which the lymphatics run through or around, which is the internal jugular vein and the spinal accessory nerve or Levens nerve, and the SCM or sternocleidomastoid muscle, means that it's a radical neck dissection. You remove everything, basically. You remove all the lymph node level from level 1 to level 5, and sometimes going to level 6, as we were talking about, especially in midline structures or a thyroid cancer. So 1 to 5, and we remove all these lymph nodes and fibrofatty tissue. And probably these lymph nodes cannot be separable from these structures. Because of that, you remove all the package with the SCM and spinal accessory and internal jugular, and this is called the radical neck dissection. If we be able to preserve one of the structures and remove like the other two, or remove or preserve two and remove one, or even preserve everything, but you have to do all the comprehensive neck dissections, then we call it a modified radical neck dissection. So basically you preserve one structure or two or three, and remove all the lymph nodes with the fibrofatty tissue. It's all the lymph nodes, like from level 1 to level 5, basically. So if I'm talking about preserving the spinal accessory, which is have a priority in the neck, because it's supplying the shoulder, even if you can sacrifice the SCM, but still this nerve is very precious because it supplies the trapezius, and that's responsible for shoulder drop. If you preserve this nerves, then it's a modified neck dissection type 1. If you preserve that and the other important structure responsible for a venous drainage of the neck on that side is the internal jugular vein, that's the second important structure. If you preserve the spinal accessory and the internal jugular vein, that's a modified radical neck dissection type 2. And the last or the least structure of importance, was still important for head movement, but it's not that important, is the SCM. So preserve that as well, then it's a comprehensive neck dissection. You remove all the lymph nodes and fibrofatty tissue, but you preserve all the structures. This is again called a modified radical neck dissection type 3. So type 1 structure, spinal accessory, with the importance in descending importance, like coming with the more important to the less important. Number 2, modified radical type 2, you preserve two structures, which is the spinal accessory and internal jugular, and modified radical type 3, you preserve basically all the structures, but you have to remove all the lymph nodes from 1 to 5 with all the fibrofatty tissue between the SCM, which is the investing layer of the deep cervical fascia, and the fascia, the deep layer of deep cervical fascia above the cervical rootlets. That's a modified radical type 3. If you just take some levels, and according to the anatomy and according to the primary structure, you're talking about a selective neck dissection. You should remove from 1 to 5. You can remove 1 to 3, which is called 1 to 3 neck dissection, or the level 3 is above the omohyoid. We call it supraomohyoid neck dissection, or a lateral neck dissection, which means that 2, 3, 4, or posterolateral neck dissection 2, 3, 4, 5, because we're talking about level 5 behind the SCM, or anterolateral neck dissection if you're talking about 1 to 4. Sometimes we do that in tongue cancers, advanced tongue cancers, or oral cavity cancer, or alveolar margin cancer. And the last thing is the level 6, which is usually a midline structures going even to the level 7, which is the superior mediastinal. This is called a central neck dissection. So if you remove only the lymph nodes with a fibrofatty tissue around it in a certain level, that's called a selective neck dissection. Even you can go for a super selective neck dissection, which means that you're picking actually some lymph nodes, which is not very common in practice, but we can consider that in cases of N0 neck if it's been radiated before. It's called a super selective neck dissection. Okay. So that's some definitions. And as far as you can see, this is one of the patients, a good neck surgery, a good neck dissection. And this is the spinal accessory nerve. And you can see the carotid sheath. This is the carotid, and this is the vagus. And this is internal jugular. And you see here, I'm taking the fibrofatty tissue with fascia around it from actually the cervical rootlets all the way underneath the SCM, which is this muscle, and going all the way to the midline. So this is a good neck dissection. You should see that. I'm not saying it because I did it. Sorry, just about this is the way I like to do my neck dissections, or see my trainee to do it. When they have this floor is clear, there is a fascial layer over the cervical rootlets. That means they clear everything without going deeper. That should be easy if you work on this plane, and in the right plane, this should come off easily up to the carotid sheath. And then from the carotid sheath, the carotid sheath has 3 layers. You go from deep to superficial. When you go to the carotid sheath, so you see the vagus, you see the carotid, and then you see the jaw. And this is the way you are escalating your neck dissection almost all the way up to get into, again, from the deep layer until the superficial investing layer, because the carotid sheath has all 3 layers. Okay. All right. So talking back about the levels, we have this is a Slough Memorial Kettering, which is a very famous cancer center in New York. Pleased to know some people working there. This is like being suggested by Professor Jatin Shah earlier, I would say 90s or late 90s, talking about the different neck node levels, and because this is important when you're thinking about where's the primary and what the lymph node levels they can go through to consider neck dissection. So level 1 is actually below the mandible and above the digastric, which is a very, very important muscle. If it's between the anterior period of the gastric and the midline above the hyoid bone, it's 1A. That's very important, 1A, when you consider doing a tongue cancer or oral cavity cancer or floor of mouth, which is our maxillofacial colleagues usually do in United Kingdom. However, in other areas in the world, if you as an ENT surgeon or head and neck surgeon do it, you do it in the way you have not to miss 1A. If you're talking about a floor of mouth, or oral cavity cancer or tongue tip cancer, that's one node you shouldn't miss. The 1B, which is below the mandible actually, and above the digastric, between the posterior berry of the digastric and anterior berry of digastric, and this is where we have the submandibular gland. Coming back to level 1B, which is below the mandible and above the anterior and posterior belly of the digastric, containing the submandibular gland, as we mentioned. Usually, it's not so simple like this with the submandibular gland. There are a few nodes around the submandibular gland and the big vessels here, which is a facial vein and a facial artery called the prevascular and postvascular lymph node. So whenever you want to clear this area, you have to clear this area with these little nodes just below the marginal mandibular nerve. It's not like just taking the submandibular gland as original ENT training is. So you have to see the marginal and go below it and dissect all the lymph node levels. And sometimes you have to preserve some of the vessels for the micro at the end. Anyway, that's 1B. 1A and 1B is usually involved in oral cavity cancer, floor of mouth or tongue. And then we have level 2 between the skull base and above the hyoid bone. And actually, it's as simple as it is from the skull base till the hyoid bone. There is a landmark here, which is a posterior periodigastric above, which is crossing on top of the jaw. And there is an important nerve here coming from the skull base, crossing the jaw in 70% of cases. Sometimes it's deep to the jaw in 30 or 25 to 26, 27% of cases, which is called the spinal accessories going from the skull base going to the SCM. And this is dividing actually level 2 into 2A, which is anterior and the inferior to the spinal accessory, and 2B, which is posterior and superior to the spinal accessory. So actually, when I'm going to level 2, I usually unzip the muscle, the SCM, to find the spinal accessory and the digastric. And then I know like anything inferior above the jaw and the inferior to the spinal accessory is 2A. Anything above the spinal accessory and between the floor and the of the muscles and the SCM, nothing here to worry about, is 2B. And that's a matter of discussion how to do the neck dissection, but just a little bit of tips for you to know. That's another topic. We can have another presentation or a course about it. Level 3 is between the digastric and the hyoid bone and the cricoid, and there is here an important muscle coming from the hyoid, getting across the level of the cricoid, which is called an omohyoid muscle. This omohyoid muscle dividing between level 3 and level 4. So level 3 is actually below the digastric and hyoid bone and above the omohyoid, okay? And it's actually between under the SCM. Here we have the rootlets and the carotid sheath. That's it. Level 4 is below the omohyoid muscle, so you have to cut it or retract the omohyoid muscle to see level 4. And you remember, level 4 on the left side, there will be a nearby important structure or a duct called the thoracic duct, which is actually draining the lymph from all the body except the upper head and neck area and upper limb, all the body on the left side and all the body except the right upper limb and right head and neck, or right face or right head and neck, is all going to the thoracic duct, and usually it's inserted below the level 4 in the lateral border of the jaw, so it's between the jaw and the subclavian. And when you go down to level 4, this area on the left side can be really tricky. Then you can have a chyle leak if you injure the thoracic duct. Unusual to happen on the right upper limb and the right side, because the right lymphatic duct is usually in the chest. However, sometimes for very unusual scenarios, it could be a high riding lymphatic duct on the right side. When you do level 4 on the right side, it might end up with a chyle leak. It's unusual, but more common on the left side, okay? Level 5 is actually behind the SCM. And we mentioned all this lymph node is between the investing layer of deep cervical fascia. So classically, you have to unzip the muscle or get the fascia around the muscle, and the deep layer of deep cervical fascia, which is actually the deep layer of the deep cervical fascia above the prevertebral fascia. So you have to get the level between the SCM and the level of the floor. And here you crossing, as I mentioned earlier, about the carotid sheath in different levels, carotid, vagus, and then jug. And this is like getting you all the right plane that you have to do a clean, comprehensive, or good neck dissection, okay? Behind the SCM is where it's going, the spinal accessory nerve, because it's the exit point of the spinal accessory nerve. It's actually the landmark here is so simple: digastric, posterior belly, jug, 70%. So the nerve will be superficial to it. In 20 to 28% or 29%, it could be deep to the jaw. And the other landmark is it's crossing inside the exit point, the entry point into the SCM is between the upper third and lower 2/3 of the SCM. When it's getting out in this area. this area is marked with another nerve. This nerve is crossing over crossing actually under the getting out of the ACM here is called the greatoauricular nerve, and this is called an herpes point. The herpes point is a point where the cervical rootlets going to have the cervical nerves, and especially the greatoauricular nerve supplying the sensation of the parotid area. So the herpes point, a centimeter above it, is where you can have the exit point of the spinal accessory, where it can go in the posterior triangle between the trapezius and the SCM in level 5. This is level 5 area, divided by the spinal accessory into 5A and 5B. 5B is actually supraclavicular node. And you have here an important structure as well, which is the inferior belly of the omohyoid. And there will be a transverse cervical vessels as well. So actually level 5A is connected to level 2B because it's above spinal accessory as well, but that's 5 behind the ACM. So whenever you do a deep level 2B, you're getting into 5A. However, 5B, you will never get through it except if you find the spinal accessory, and you will find here the omohyoid, inferior belly, and some vessels, which is transverse cervical vessels coming from the subclavian. And sometimes if you need to do a supraclavicular flap or anything, you have to preserve it anyway. So that's 5A and 5B, and you unusually go for a 5 neck dissection, level 5, except if there is a posterior scalp or an occiput or a huge parotid tumor or a skin cancer metastasizing to level 5. Then you have to see the spinal accessory, and the spinal accessory last landmark, it enter into the trapezius 5 centimeters above the clavicle. This is why it's important nerve to supply the trapezius where it can help with the shoulder elevation. Otherwise, shoulder drop if the nerve is affected here. Okay. Level 6 is this area, central component, which is between actually the carotid, medially, common carotid, and the midline structures, and is crossing again with the nerve, which is a recurrent laryngeal nerve and parathyroid glands. So it's actually, if the area between the carotid, common carotid, and the trachea, crossing by the current laryngeal nerve, you can find the lymph node medial to the carotid or medial to the recurrent laryngeal nerve. So all this area needs to be cleaned all the way down to the superior mediastinum. If you're talking about level 7 neck dissection, sometimes you pull the thymus, and remember, you can have a central leak as well, lymphatic leak. So you have to get to the point, if you don't feel lymph node, just put a clips and then take everything off. And you have to see the recurrent laryngeal nerve definitely at that point. And this neck dissection central component is usually associated with a temporary hypoparathyroidism because you're working around the parathyroid even if you preserve it. Sometimes it's hard to preserve it, but you have to. Okay, so that's regarding the neck levels. So what's N0 neck and N plus neck? That's another definition which is very important. N0 neck is clinically and radiologically free. You cannot find any positive lymph node. Clinically, you don't feel any lymph node, or radiologically suggestive of a metastatic node. So what's the radiological criteria, and what's the scans that you order to know if there is a positive metastasis or not? And again, this is something not 100% proven. It's suggestive. So N plus is a palpable or a radiologically positive node, but we're talking about if to prove it's a cancer and where it comes from, we have to do an FNA definitely or a core needle. So criteria, depending on the scan you are ordering, if you're ordering a CT scan with contrast or an MRI, like more than a centimeter, regular outlines, if you have a central necrosis and peripheral enhancements, that's definitely a metastatic node coming from probably an SCC. If there is a microcalcification, cystic degeneration, or even solid and irregular outline and microcalcification, probably it's a metastatic node coming from PTC or a papillary thyroid cancer. Again, it could be multiple nodes and no central necrosis, and if it's multiple and bilateral cell lymphoma. So we need, again, an ultrasound FNA or an ultrasound core needle actually for lymphoma, to confirm. Now we are shifting. If the node is big enough, you go to ultrasound core needle. That's even giving you better information rather than the fine needle. Maybe the fine needle is useful in cystic nodes rather than solid nodes, okay? So if there is no palpable nodes clinically or radiologically, and this is a scan, very important scan, sometimes you order it when you are having some nodes and you are not sure, or it's been ultrasound needled or cored, and there was a positive evidence of an SCC, and you don't know where the primary. This is called a PET-CT. So even if when you're talking about N0 neck, it's clinically and radiologically up to PET-CT is negative. You are not ordering a PET-CT if it's a negative clinically and radiologically with the simple scans like CT and MRI. However, if you have any proven still, if you have a proven primary or a proven neck metastasis and a small node, and you cannot feel it well, but like there is scans or there is a primary suggestive there is a primary, and you need to do a PET for any reason, and the PET is showing up, that's again something you have to, although it's not the usual practice. That's again a positive node. So positive node, it means that radiologically and clinically, if it's positive, then it's N plus. Again, it's something needs to be confirmed pathologically with some means like a core needle or an ultrasound fine needle, guided fine needle, or even in the operation itself. If it's you cannot feel any lymph node clinically and radiologically, then it's N0 neck. So the question is, if there is an N0 neck, should we do a neck dissection? That's another question and something we started about some definitions, and now we come for concepts and questions. N0 neck, should I do neck dissection? That's very crucial question. If it's an N0 neck, should I do neck dissection or not? Because there is no evidence. I can do a CT MRI, or I can do an MRI and PET-CT, no node, or and with the ultrasound CT MRI PET-CT, no node. So I shouldn't do a neck dissection, right? No. The question is, if they have made a very comprehensive review about the primaries and the necks done for everybody, and that was a big institution. Usually these studies are done in the United States, not very biased against them, but with them, sorry. But they are having definitely very well-established practice in many cases. So because of that, these studies are really very robust and very solid. So I was pleased to work with this gentleman, Professor Medina, and he did that paper talking about what's the indications of neck dissection in N0 neck. And they found that concept. If the risk of occult neck disease is more than 15 to 20%, then you have to do a neck dissection, even if it's an N0 neck, okay? Because survival and the recurrence rate will be quite high if you don't do a neck dissection. So if the risk of occult primary is 15 to 20%, you have to do a neck dissection, even if it's an N0 neck, okay? And how they know that? They look into all the neck dissection specimens and they look for the primary. And even like for the N0 necks, they found like in some cancers, they have microscopic deposits and it still is N0. And depending actually on the type of cancer, where it come from or where the primary is, and if the primary, and they made like that association, if the primary have an incidence of occult, what is mean by occult? It means that it's an N0 neck only detected pathologically. If the incidence is more than 15 to 20%, see, you have to do an elective neck dissection, which is a very important term. It's not like a therapeutic one because it's still an N0 neck, or what is called elective or a prophylactic neck dissection if that risk is that much. So another question for you guys, if it's an N0 neck, there are like a debate about this is positive nodes. Shall I go very radical just to clear everything and make sure the recurrence rate will be quite low? Or shall I again have to make a balance between the morbidities of removing everything in the neck with the lymph-bearing structures, SCM, the spinal accessory specifically, and also the internal jugular, and I shouldn't do that. So what's the rationale? Either should be radical or should be less radical? Is there any answer for that? Yeah, there was. Try to be selective. Why? Usually the old consensus of the old schools about you have to be in positive neck, you have to be at least a modified radical neck dissection. That's a very, very, very solid concept that has been changed. And why? Because you cannot still, if you have a microscopic extracapsular spread, and doesn't mean that removing the structures around it will get you 100% cure. You still have other options and other weapons that can play a role, which is actually radiation in cases of an SCC, and probably you're looking for radiation of the primary sometimes as well. So if you do have alternative or complementary tickets or weapons that can help with you, then why you have to be so radical? You shouldn't, especially with the morbidity coming for being too radical for no sense. And you still, when you have, you discuss your cases in the MDT and it's an extra capsular, and even if you removed everything, the MDT will suggest, or the tumor board, they will suggest an adjuvant radiation. So until you have an complementary or adjuvant route of treatments, then you shouldn't be that radical. Try to be selective. There is definitely a role for an adjuvant treatment. So now is most of the people are replacing the radical neck dissection with even modified, or sometimes it's even selective neck dissection if you can, not compromising your oncological surgery. I mean, like if you can dissect the lymph node with removing all that you can do in terms of the cancer, without leaving a significant macroscopic residual disease, then you are doing the job. However, there was like this nerve was really sticky, or the jug I'm trying to dissect from it, I was successful, but I was very close, or I take part of the muscle rather than the whole muscle. It's again an accepted oncological resection until you don't leave any macroscopic cancer. However, if you leave it, you have to be modified radical or radical. And radical neck dissection, and actually, or a modified radical, is still employed in a bulky nodal disease of the neck when there is an extensive soft tissue development, because you cannot separate the node from the jug, you cannot separate the nodes from the spinal accessory. If you try, you get the cancer to be spread because you are working in the cancer, you're disrupting the roots. So if you can be selective or a modified radical, that would be ideal. If you cannot, because it's an extensive nodal disease with extensive soft tissue involvement, and that's an information you can get from your scans preoperatively, try to be, then there is no question you have to be radical or modified radical by then. Okay? The same for radiation. If it's a radiated neck and has a positive neck disease, it's really unusual to be selected. So they'll end up at least with a modified radical or a radical. For two reasons here in a salvage neck, because that's the last option for the patient, so you cannot leave anything. The other thing is there will be tough neck. So if it's a radiated neck and has a positive nodal disease, I will have low threshold to spend any time to do a selective neck dissection. It's a positive node, and he is not responded to radiation, and definitely this field will be so scarred and so sticky. So you have to be modified radical, being sensible, and at the same time being oncologically safe. Okay. So how about selective? It means that you even look one or two levels. That's again a question I talked with you about it. Usually they're thinking about to be super selective, to preserve 2B, and to preserve the contralateral neck. And that's again questions. And that's a realistic answer in when you're talking about the primary. If you're talking about the thyroid cancer as a primary, when you're doing a neck dissection, you don't need to go for a 2B, except if the 2A is really involved, or sometimes even with the 2A involved, and it's not a big bulky nodal disease, you need to spare 2B, because working around the spinal accessory is not about the surgical fun. No, it's about you devascularize the vessels around the nerve, and it will end up with an intact nerve grossly. However, within a few weeks or a few months, a patient presented again with shoulder drop. Why? Simply because you disrupt the vessels around it. So superselective neck dissection, it can be a concept, especially if in N0 neck, in radiated neck, sometimes if you need to do it. And I have a paper talking about, and you don't need to do a contralateral neck or comprehensive selective neck dissection in salvage laryngectomies or laryngopharyngectomies, especially if it's till it's an N0 neck. Some cancers as well, like a thyroid cancer, you don't need to do 2B, you don't need to do the contralateral neck. So there is no point to do it because the incidence of focal neck disease here will be again less than 15 to 20%. So doing extra is not good because sometimes it's carry more morbidities, especially if it doesn't offer any oncological value. Okay, so talking about another question, is it an FC lateral or a bilateral neck dissection? Should I do FC lateral or bilateral? What's the consensus for this? There is a very important rule is the tumor is midline or approaching midline, especially we're talking about supraglottic or tongue base or even oral cavity cancer. If the tumor is midline or crossing midline, like it's big enough to approach a midline, advanced stage, we have to consider the contralateral neck either by radiation or preferably actually by surgery, because if the patient is elected for surgery, so you are doing the surgery. So why you have to do one neck without doing the other? The patient will go for radiations, and you have to consider the contralateral neck. That's an oncological concept, okay? So again, if it's an M positive after chemoradiation, is there is any role for any other treatment? If you're going to operate, then you have to operate, no other options as a complementary option or adjuvant option. Here, you have to be, if you can be selective, that's fine, or super selective. However, if it's an M positive, you cannot be selective or super selective. So you have to be at that point to do a modified radical or radical neck dissection. If it's an N0, then you don't need to do it. If you want to do it, you will do a super selective neck dissection. And actually, I would say I would do still right now a super selective neck dissection in an N0 neck after chemoradiation, just in case if there is any even microscopic deposits. Even I don't see even the ratio is less than 15%. And usually you need that if you consider doing a free flap for micro. And here is a positive. This is CRT. You know the concept about when you're doing a chemoradiation for a primary in the head and neck, for squamous cell carcinoma and head and neck, you do a chemoradiation. We talked about this in laryngectomy presentation. And we know, like after chemoradiation with 3 months, you have to do a PET-CT. And if there is high uptake, more than 3.5 SUV volume, or very high, and this persistent, then you know there is a neck disease. Even if you cannot prove in with an ultrasound guided, sometimes you can do an ultrasound guided or a core. But if there is a persistent nodal disease and it's positive, it's unusual to be able to be a super selective or a selective neck dissection. At least you have to be selective. But if you really struggle and it's really big node, then I would say modified radical or radical is considered in that situation. Okay. When to do a neck dissection in positive neck, that's after chemoradiation. We talked about it, 12 weeks after CRT, 3 months. And sometimes people will push it for 4 months. And that's again has been already a consensus and been agreed. You cannot do a neck dissection before 12 weeks because like you have to do the PET-CT scan anyway after 12 weeks or 3 months. Before, if you're doing that before, it will be positive PET-CT and no sense. And if you're doing a neck dissection, you are offering something for a patient that it could be have N0 neck, still like it has a positive PET-CT before the 12 weeks, but still a positive signal, but still when you're operating on it, there will be no tumor. And that's a paper already has been agreed. So you do a PET-CT, as I mentioned, and after 3 months or 12 weeks, and if it's still positive and high signals, then you can consider doing a neck dissection. If it's a low signal, you can repeat it in a month after. And if it's still positive, you offer neck dissection definitely. And then we talked about you can be selective, but it will be tough. So probably you will go for a modified radical or radical. And that's a Mihana paper talking about the PET-CT study when you're doing it twice 12-week time frame, because you're looking for all the necks have been done before 12 weeks, and the PET CT scan was being done before the 12 weeks, and they found actually then if they do the PET CT before 12 weeks, they will have a positive signal, and when they do a neck dissection, there will be no tumor, and that offer no survival benefit, okay? Okay, so coming back to the primary tumor and the risk of occult neck disease. So we can go through quickly and comprehensively all the head and neck cancer primary, and we'll talk about what you will do in each of them. Because we talked about in N0 neck specifically, we agreed about N positive, we do a therapeutic neck dissection, and N positive here is positive by clinical and radiological, and the answer is easy. If it's a primary, no history of radiation or chemoradiation, you go for selective neck dissection if you can. If it's a grossly nodal disease with soft tissue involvement, then you can consider modified radical or radical. And again, you offer a primary surgery as for the primary tumor as well. If the patient's primary treatment is chemoradiation, so you wait until 12 weeks or sometimes 16 weeks, and you do the PET CT. If the PET CT is negative, that's fine. For the neck, you don't need to do anything. If it's positive, then you consider doing a salvage neck dissection, and that would be try to be selective if you can. No rule. I'm sorry, no rule for a super selective. It could be selective, or actually, the realistic situation, try to be modified radical rather than radical, or could be radical in sometimes, because that's a less chance for the patient. If it's an N0 neck, and you still have a primary PET CT as a show the primary, and you do a surgery for the primary, then the neck can be done with a super selective neck dissection if it's an operative or it's an open surgery. Okay, so if it's an NPOL plus after CRT, we know the answer: modified radical or radical. If you can be successful with selective, that would be okay, but unusual. If it's an N0 neck after CRT and PET CT is negative, but there is a positive signal from PET CT in the primary, and you are going to operate on the primary, you don't need to do the neck. That's an accepted option. Or I would prefer to be super selective, especially because if you consider removing the round, like the lymph nodes close by, and you will do it anyway for if you consider doing a free flap option, especially for a laryngectomy or laryngopharyngectomy. Okay, so for super selective, I mean for laryngectomy or laryngopharyngectomy, FC lateral area level 2 and 3, even if it's an N0 neck, but the primary is there in the larynx or hypopharynx. Okay. Oropharyngeal tumors. So it's N0 neck and no, and there is a primary, and we are doing a surgery for the primary. What will be our rationale of doing a neck dissection? We talked about if the primary could be associated with an occult neck disease with 15 to 20%. That's the original, the first concept. You have to do a neck dissection on as a prophylactic or an elective basis. And that's regarding one of the tumors that you have to do, consider treating the neck no matter what, as a bioradiation or a surgery, especially nowadays we're doing robotic surgery for early T1, T2, oropharyngeal or tonsillar SCC. So if you are doing a neck dissection and the primary treatment for an oropharyngeal cancer will be T1, T2, you will do a surgery rather than radiation or chemoradiation, then you have to do, again, if it's T1, you have to do even if N0 neck, because the risk of occult neck disease in tonsil or tongue base or posterior pharyngeal wall usually more than 15 to 20%. So you have to treat the neck at least on one side with 2, 3, 4 neck dissection, even if it's an N0 neck. And you deal with the primary surgically, usually by tumors. Okay? If the tumor is big enough, which is unusual for a tonsil or tongue base, or if it's a tongue base is still T1, T2, it's a midline or approaching midline, then you have to consider doing a contralateral neck as well, even if it's an N0 neck, until the treatment is surgical. If the treatment is radiation, they will radiate the primary, and depending on the size of the tumor and the stage and the location, they will radiate the neck ipsilateral or bilateral. And again, after 12 to 16 weeks, you got the PET CT to look for the response. If the response is there, we are all happy in the MDT. If the response showing there is increased uptake in the node, then you consider doing a neck dissection. If there is increased uptake in the primary, but no evidence in the node, so again, you should consider doing, the term you should is not, we prefer to do a super selective neck dissection, and the consensus, you don't need to do any neck dissection sometimes, even if you treat the primary with surgery, if there is any uptake in the primary. If no uptake in the primary, no uptake in the neck, we are happy, no need to do anything. Oral cavity SCC, and again, it's if it's an N0 neck, if the tumor is T1, tongue, floor of mouth, under surface of the tongue is not midline or not approaching midline, then again, you do here FC lateral neck dissection, because the risk of occult neck disease will be 15 to 20%. And here you're doing a supraomohyoid neck dissection 1, 2, 3, 1A, 1B, and 2 and 3. Okay, and that's for an N0 neck. You consider doing the contralateral neck if the primary tumor is in midline, like tip of the tongue or floor of mouth, or it's big enough, like T3 and T4 tongue cancer, it's definitely crossing the midline because it's really big. Then you have to consider doing a contralateral neck dissection as an elective neck dissection. If it's an N positive neck, we know the answer. You do at least, depending on, you do at least the FC lateral neck. You can sometimes do the contralateral neck if the primary, depending on the primary, if it's big enough. And here you will be doing a selective neck dissection if you can. And if it's really bulky nodal disease, you can do a modified radical or radical neck dissection. But usually try to be selective, especially this is a primary treatment with surgery. It's no radiation, nothing. So, and still patient will go for radiation adjuvant. Try to be selective to be less morbid. And for oral cavity cancer as well, you don't need to do 2B. Except if 2A is really involved. So it's unusual actually in oral cavity cancer. But definitely in oropharyngeal cancer and laryngeal cancer and hypopharyngeal cancer, you need to do 2B no matter what. In supraglottic, yes, which is any cancer in the epiglottis area, epiglottic fold of the ventricle above the vocal cord, you have to do neck dissection, and we do it on both sides. If the primary treatment is surgery, old days it was by open surgery, now with laser or a robot. So you do, or if you treat it with radiation, you have to consider radiating the contralateral neck, because the risk of occult neck disease, bilateral neck disease, is more 15 to 20%. In glottic cancer, it's post-lymphatics, no lymphatics for vocal cords, so you don't need to do any neck dissection for the treated glottic cancer, even up to T3, because it's again, it's no lymphatics, so no need to do neck dissection. And usually we treat those T1, T2 glottic SCC with laser, and we don't open the neck for that. And in T3, you treat it with a CRT as an organ preservation protocol. And at that point, if the primary is glottic and there is minimal supraglottic involvement, even you can spare the neck from radiation. T4 glottic, subglottic, or subglottic cancer. Here the primary is advanced, you radiate the neck. So you treat it, is T4 usually treated by surgery with a laryngectomy, because it's a locally advanced, and you will consider adjuvant radiation for the primary. Here, there is a debate about if you want to do a bilateral neck or obstilateral neck or not. There is a debate about it. It's no great right or wrong answers, although at least in T4 glottic, subglottic SCC, or a subglottic, if there is a supraglottic involvement, I will go for both sides as usual with the supraglottic. If it's a glottic or subglottic, even if it's a high advanced T4, you might consider only doing the FC lateral neck, but that's not, there is no consensus about it. Sometimes they call it in subglottic cancer, you need to do at least level 6 neck dissection, which I agree, up to the mediastinal, but you don't need to do 2, 3, 4 on both sides. However, the consensus is, to be honest with you guys, we usually offer laryngectomy as a primary laryngectomy on bilateral neck dissection. What we're making is right, we don't know so far. And if you spare the contralateral neck, will be any problem? I would say usually not. However, at least you do one side neck and focus on the level 6 if there is a subglottic involvement, okay? And basically what happens is if one side is affected, you will radiate the other side prophylactically in terms of the neck levels. That's again something can be discussed in the MDT, but no consensus about it. Supraglottic, you do bilateral treatment of the neck with radiation or neck dissection in any stage. Glottic, subglottic, there is a debate. If it's really advanced and you will offer surgery, you probably will do at least one side on the affected side, and you focus on the level 6. Hypopharyngeal cancer, this is again something we really offer in nowadays, radiation or chemoradiation for T1 up to T3. And if it's a T4 really big tumor, hypopharyngeal piriform definitely will cross the midline, posteropharyngeal wall, post-cricoid. So we know the answer. If you do a surgery, you will treat the neck on both sides. And again, you have to dissect level 6 as well. So 2, 3, 4, 6 on both sides. Okay. And if there is a clinically positive node, modified neck dissection or radical neck dissection can be affected, can be done. And remember, there is like a subtle nodes usually in retropharyngeal area. It's called Riviere nodes. You have to think about it, look into it, into the scans before considering when you're doing your neck dissection as well. And even if they offer radiation, they will offer radiation for both necks for advanced hypopharyngeal cancer T3, both necks and the primary as well. That's a paper being published by Mr. Tracy. I had pleasure to work with him in Birmingham at some point. And that's UK like national multidisciplinary MDT guidelines for treatment of hypopharyngeal cancer. And this is a sentence regarding the lymph nodes. How about thyroid cancer? We're coming close to the end. So again, thyroid cancer is a very good surgically treated disease. And the consensus here, do we need to do a neck or not? So proponents of doing the neck, there is a high, the one is going with to do the neck because there is a high risk of nodal involvement. The against, and there is, it's inaccessible during the surgery. Opponents of that, there is no survival benefits and increase in complication rate. So what we will do? So again, it's so simple. Is the risk, the answer come back to the 15-20%. And if the risk of 15-20% of occult neck disease is less, that's in N0 neck, in papillary and follicular cancer, differentiated thyroid cancer, you don't need to do the neck prophylactically, even level 6. We don't need to do it in papillary and follicular. Even if it's a T, sometimes people say T3, thyroid cancer, PTC, a papillary or a follicular, you can consider doing a central neck dissection, but you don't need to. You don't have to. I mean, you can, but you don't have to. If, because the risk is below at 20%, okay? And if it's an N0 neck, we know the answer. We have to go for a neck dissection, depending on the levels. If the central neck is affected, you go for a central neck dissection. If the lateral level is affected for a PTC or a follicular cancer, you go for a central before the lateral, 2, 3, 4. And even sometimes you pull level 5 from with you as well, because it's always, if it's a metastatic to the lateral neck, it will go first to the central neck, crossing it to the lateral neck, and let's go to the different levels of nodes. So 2 to 5 and central as well. So 2 to 6 on one side. You don't need to do the other side. That's for a papillary thyroid cancer and follicular. If you're talking about a medullary thyroid cancer, different story, because the risk of occult neck disease, even if small medullary cancer, is more than 15 to 20%. So even if the N0 neck, you have to do at least central neck dissection. If it's an N positive, you have to do a central neck dissection and go further step, because there is a risk of occult neck disease. You go central and lateral neck dissection. If there is a lateral neck, N0, N plus, you have to do central and lateral as a therapeutic neck dissection. So for a medullary thyroid cancer, if there is N0 neck, you still have to do a prophylactic neck dissection. If it's N plus neck, you have to do a therapeutic neck dissection, central compartment, and consider as well, even if the lateral compartment is free, to do a prophylactic neck dissection. If there is a lateral node in the medullary cancer, you know the answer. You have to do central and lateral neck dissection. But you don't need to consider contralateral neck because the risk of contralateral neck disease is usually below than 15 to 20%. Last thing, talking about the cutaneous SCC, is a skin cancer in the face. In that cases, they're usually done by plastic in some units, and in other units, which I consider you guys to think about it, this is something related to the ENT. So skin cancer related to the ENT, and if you're doing it, you're thinking about it like Max Fats of plastic can do it, but you have to think about to do it exactly like the States. Cutaneous SCC, if there is no in the face or the neck, you do your surgery, your primary, or treatment is radiation. You don't need to worry about any lymph nodes if it's an N0. If it's an N plus neck, or a metastasis in the parotid, because this is the patient that goes through first, parotid, and then it goes to the neck. So if the neck is positive, then you have to do a parotid probably. So you have to do, because a parotid usually is the first station before going to the neck. So if the parotid is involved later on, which can be presented in your exams, usually by parotid lump, and this is, you have to ask about history of skin cancer operation. And if it's been proven as a metastatic SCC in the parotid, you should do at least a superficial parotidectomy and a prophylactic 1 to 3 neck dissection. Okay. If the neck node is involved, like a lateral neck, and the parotid is not, which is really unusual, it means that there is an occult disease that has been popped up yet. It popped up in the lymph node. So again, if the location of the cancer is anterior to the tragus, you consider doing a superficial parotid as a matter of prophylactic neck dissection, and you do 2, 3, 4 neck dissection. And if the cancer is behind, then you can consider behind the tragus, you can consider doing 2 to 5, 2, 3, 4, 5. We can spare the parotid at some point because it's supposed the cancer was originally in the posterior to the tragus or posterior to the ear, and usually go to the level 2 and 5. It's no point to go to the parotid. So the cancer in the face and there is a positive node, then you have to do a parotid and a prophylactic 1 to 3 neck dissection. If the lateral node is involved and the cancer was in the face, you do 2, 3, 4, and sometimes 1, 2, 3, 4 or 2, 3, 4. It's okay, and you're doing a parotid as an extra bonus because probably the cancer is occult there, but not popped up yet. And if the cancer is primary in the occult, in the posterior to the occiput behind the ear, then you do, and there is a nodal metastasis, because if there is no nodal metastasis, you don't do anything. If there is a nodal metastasis at level 2 or level 5, you do 2 to 5 neck dissection, and you don't need to worry much about the parotid because that's a cancer was originally in the occiput. The last thing is about the concept of central lymph node biopsy. What is the central node? Central node, just to analyze the lecture and conclude it, central node is a node that it is an N0 neck, but still there is a risk of occult metastasis. The first echelon node or echelon node is the first basin of nodes that the cancer can go through. It's just we're doing as a prophylactic thing. Central lymph node has never been N plus, it's an N0, and this is the first basin, lymph node basins that the cancer can go through, the first stations that the cancer can travel to, and even if it didn't travel yet, okay? And the way to know it, you can inject the primary with an insulin blue, or better, you put like a radioisotope in the primary, and this is well established in the breast cancer. We're doing it in melanomatous cancer in the face. On some trials was talking about N0 neck in T1 SCC of the tongue. You either to do nothing or you do a central lymph node trial. So the sentinel lymph node is an N0 node, but it's the first echelon or a first basin of the station of the lymph node. That's never been positive, but it can be positive in the future. The way to do it, inject a methylene blue or a radioisotope, and you do a scintigraphy, then the radioisotope will be showed up immediately in the primary, and can travel to a lymph node in nearby, and then intraoperatively you confirm it with a gigameter that can measure the isotope activity. Usually the isotope activity in the primary site of melanoma will be high, and in the first echelon node will be high. When you take the lymph node out and you put the probe again, or a gamma probe again, then the activity will be definitely so less, up to be 10% from the activity that has been reported in the primary. So let's say the primary activity is 4,000 or actually 500. And then in the lymph nodes is like 100, or the area where it's being shown up with the scintigraphy. In this area, let's say if there is a melanoma in the face and the nearby area is the level 1B, and you, instead of doing a prophylactic level 1B neck dissection or 2 neck dissection, you inject, because it's an N0 neck, and the isotope is being concentrated in the primary and go to some nearby structure near level 1, and then you go ahead and you open a minimally invasive approach to get the lymph node out, and you don't know, is it the node, right node or not? If you get things out, you measure again with the radioisotope, a probe, a gamma probe. If the activity is less than 10%, like less than 40 or 50 from 540, 500 or 400, then you know you got the lymph node out, okay? Is the activity remaining in the tissue after you taking the node out, then you got the central node. And again, that's an important concept for a melanoma rather than anything else. And there is a debate about it. Is it really useful? Some people will say, yeah, it improves the local control of the disease, prevent any recurrence of melanoma in the future in this area. However, it doesn't offer any survival benefit, and we usually consider it for even stage 1B when there is an ulceration with a small melanoma. MSLT trials saying that there is local regional control for a sentinel lymph node biopsy, and if the sentinel lymph node come back as positive, what you do? You can do at that point a prophylactic dissection with a level and the nearby level, and that's again, if it come back as negative, then you know, like, there is no cancer there. So that's improving the local regional control. However, it doesn't offer any survival benefit, to be honest. So because on the long term, you need sometimes when there is a big melanoma or stage 1B, some centers will offer even a immunotherapy for them rather than just to offer, or if there is a positive node, they can do at that point a neck dissection, or even sometimes the immunotherapy can be done as a salvage option, or immunotherapy can be done for those patients. So is it important? Yes, it could be considered, agree. Improve local control, proven. However, is it offering any survival benefit? Probably not. And because you need an adjuvant treatment anyway for a melanoma with an immunotherapy, you can do the neck if you need to in the future if there is any regional failure. So T1B and T2 or above. And again, it's costly a little bit and time lengthy in terms of the procedure time when you're doing it in theater. Okay, and this is like the sentinel lymph node trial talking about stage 1 and 2, SCC in zero neck. There is no consensus about it so far. It's done in Texas, so that's it. And this is the things that I like to do at the end when I'm getting all this packet dissected over the shop. Thank you very much.